Hello and welcome. Today we will discuss ecbolics and tocolytics, which are drugs that affect uterine motility. This is one of the most clinically important topics in reproductive pharmacology because uterine contractions may either need to be stimulated or suppressed depending upon the clinical situation. Failure to induce labor appropriately can threaten both maternal and fetal health, while uncontrolled preterm uterine contractions may result in neonatal morbidity and mortality. Therefore, these drugs are highly relevant in obstetrics, emergency medicine, neonatology, and maternal-fetal medicine. So, let's start. The learning objectives are shown. Please take a look. Before discussing the drugs themselves, we first need to understand the physiology of uterine contractions. Near term, estrogen increases expression of oxytocin receptors within the uterus. Oxytocin released from the maternal and fetal posterior pituitary stimulates uterine contractions. At the same time, prostaglandins are produced locally and amplify uterine activity. Notice the positive feedback loop shown in the diagram. Uterine contractions stimulate further oxytocin and prostaglandin release, leading to progressively stronger contractions. This positive feedback mechanism is physiologically unique because most endocrine systems operate through negative feedback. Clinically, ecbolic drugs mainly amplify these natural uterotonic pathways. Conversely, tocolytics interrupt calcium signaling, prostaglandin synthesis, oxytocin activity, or myosin activation to suppress contractions. Drugs affecting uterine motility are broadly classified into uterine stimulants, called ecbolics, and uterine inhibitors, called tocolytics. Ecbolics include oxytocin, prostaglandin analogs, and ergot alkaloids. Tocolytics include calcium channel blockers, oxytocin antagonists, COX inhibitors, beta-2 agonists, and magnesium sulfate. This classification is highly mechanistic. Each class acts at a different step within the contractile pathway. For example, oxytocin increases intracellular calcium signaling, whereas nifedipine prevents calcium entry into smooth muscle cells. Understanding this mechanistic framework makes comparison between drugs much easier. Oxytocin is a peptide hormone with a very short half-life. It is usually administered intravenously because peptides are rapidly degraded in the gastrointestinal tract. Oxytocin binds to specific G protein-coupled receptors on uterine smooth muscle. Activation of these receptors increases IP3 and intracellular calcium, producing rhythmic uterine contractions. One important concept is that oxytocin-induced contractions are relatively physiological and coordinated compared with the sustained spasmodic contractions caused by some other ecbolics. Hence, it is widely used for induction and augmentation of labor. It is also critically important in management of postpartum hemorrhage because uterine contraction compresses uterine blood vessels and limits bleeding. Another interesting use is facilitation of milk ejection through nasal administration. Notice the ADH-like activity mentioned on the slide. At high doses, oxytocin may cause water retention and relative hyponatremia, potentially contributing to pulmonary edema or even seizures. Contraindications include fetal distress and situations where vaginal delivery itself is unsafe. Now let us discuss prostaglandins and their analogs, which are among the most important pharmacological regulators of uterine motility in modern obstetrics and gynecology. Prostaglandins are locally acting eicosanoids that strongly influence uterine contraction and cervical ripening. Different prostaglandins vary in receptor selectivity, potency, duration of action, and clinical applications. This explains why certain prostaglandins are preferred in specific obstetric situations. Dinoprostone is a prostaglandin E2 analog. One of its major strengths is cervical ripening. It softens and dilates the cervix, making induction of labor more physiological and controlled. This is especially useful when the cervix is initially unfavorable. In many patients, successful induction depends not only on stimulating contractions but also on preparing the cervix adequately. Misoprostol is a prostaglandin E1 analog and is one of the most widely used obstetric drugs globally. It is inexpensive, stable at room temperature, and can be administered orally, vaginally, or sublingually. Because of these properties, it is highly valuable in both advanced healthcare systems and low-resource settings. Misoprostol is used in medical abortion, induction of labor, and management of postpartum hemorrhage. Dinoprost and Carboprost are prostaglandin F2 alpha analogs. These drugs produce very strong uterine contractions. Carboprost is especially important in severe postpartum hemorrhage that does not respond adequately to oxytocin. However, because prostaglandin F2 alpha analogs can also constrict bronchial smooth muscle, bronchospasm is an important adverse effect, particularly in asthmatic patients. Gemaprost is another prostaglandin E1 analog mainly used in medical termination of pregnancy. It is effective but relatively expensive and requires refrigeration, limiting convenience compared with misoprostol. An important educational point from this slide is that prostaglandins do not simply stimulate the uterus. Different prostaglandins may preferentially influence cervical ripening, uterine tone, abortion, or postpartum hemorrhage control. Therefore, selecting the correct prostaglandin depends heavily upon the clinical objective. Dinoprostone is a prostaglandin E2 analog. It acts through specific prostaglandin receptors and increases intracellular calcium signaling. One major advantage of dinoprostone is cervical ripening. It softens and dilates the cervix, making labor induction more successful when the cervix is initially unfavorable. This is clinically extremely important because induction failure is often related to poor cervical readiness. Dinoprostone is usually administered as a vaginal pessary or tablet. Unlike oxytocin, it does not possess ADH-like activity. However, prostaglandins commonly produce gastrointestinal adverse effects including nausea, vomiting, and diarrhea. Bronchospasm may also occur because prostaglandins influence airway smooth muscle. Ergot alkaloids such as ergometrine and methylergometrine produce powerful sustained uterine contractions. Unlike oxytocin, which produces rhythmic contractions, ergot alkaloids can cause spasmodic contraction. Mechanistically, they act through alpha-1 adrenergic and serotonin receptors. Their major use is control of postpartum hemorrhage after delivery. Because they produce prolonged contraction, they are highly effective at compressing uterine blood vessels. However, these drugs are contraindicated during progressive labor because sustained uterine contraction may compromise fetal oxygenation and even produce uterine rupture. Vasospasm and hypertension are important adverse effects. This slide highlights an important pharmacological principle. The same increase in uterine contraction may be beneficial in one clinical context but dangerous in another. This summary table integrates mechanism, advantage, and limitation of the major ecbolics. Oxytocin produces physiological rhythmic contractions and remains first line for induction and postpartum hemorrhage. Dinoprostone is particularly valuable for cervical ripening. Misoprostol is inexpensive, stable at room temperature, and highly effective, making it extremely useful in low-resource settings. Tocolytics are mainly used to temporarily delay preterm delivery. An important concept is that tocolytics do not usually stop preterm labor permanently. Instead, they buy time. Even delaying labor for 24 to 48 hours may be life-saving for the fetus. This allows administration of antenatal corticosteroids such as betamethasone or dexamethasone. These corticosteroids accelerate fetal lung maturation and reduce neonatal respiratory distress syndrome. Delay may also permit transfer of the mother to a tertiary neonatal intensive care facility. Magnesium sulfate may additionally be administered for fetal neuroprotection and reduction of cerebral palsy risk in extremely premature infants. Nifedipine is one of the most commonly used modern tocolytics. Uterine smooth muscle contraction depends heavily upon calcium influx. Nifedipine blocks voltage-gated calcium channels and reduces intracellular calcium availability. As a result, uterine smooth muscle relaxes. An important advantage of nifedipine is oral administration, relatively good tolerability, and low cost. However, because it also relaxes vascular smooth muscle, maternal hypotension, flushing, and headache may occur. Clinically, nifedipine is often preferred because it balances efficacy, convenience, and safety reasonably well. Atosiban is a synthetic peptide that directly antagonizes oxytocin receptors. By blocking oxytocin signaling, it suppresses uterine contractions. Its efficacy is generally comparable to beta-2 agonists, but its adverse effect profile is significantly better. This is clinically important because older tocolytics often produced substantial maternal cardiovascular toxicity. Atosiban therefore represents a more targeted pharmacological approach. However, cost and limited availability remain important limitations. This slide demonstrates the evolution of obstetric pharmacology toward receptor-selective therapeutics. Prostaglandins strongly stimulate uterine contraction, especially prostaglandin F2-alpha. Indomethacin inhibits cyclooxygenase enzymes and reduces prostaglandin synthesis. As a result, uterine contractions decrease. This mechanism is particularly useful in early preterm labor. However, fetal toxicity is a major concern. Indomethacin may cause premature closure of the fetal ductus arteriosus. This can seriously impair fetal circulation. Other adverse effects include gastrointestinal toxicity, hepatotoxicity, dizziness, blood dyscrasias, and renal complications. This slide highlights a recurring principle in obstetric pharmacology. Drugs must always be evaluated in terms of both maternal and fetal safety. Beta-2 agonists such as ridodrine, terbutaline, and salbutamol relax uterine smooth muscle through CAMP-mediated inhibition of myosin light chain kinase. Relaxation occurs because myosin phosphorylation is reduced. These drugs can produce relatively rapid uterine relaxation. However, selectivity is imperfect. Some beta-1 stimulation occurs, leading to maternal tachycardia and palpitations. Hyperglycemia, tremors, and pulmonary edema may also occur. Because of these cardiovascular adverse effects, beta-2 agonists are used less frequently today compared with nifedipine. Magnesium sulfate is a very important obstetric drug because it has multiple clinical applications beyond simple tocolysis. Traditionally, magnesium sulfate was used as a tocolytic because it relaxes smooth muscle and suppresses uterine activity. However, modern obstetrics now values magnesium sulfate even more for fetal neuroprotection and management of eclampsia. The exact mechanism by which magnesium sulfate suppresses uterine contractions is not completely understood. However, magnesium interferes with calcium-mediated cellular activity and reduces membrane excitability in both nerves and muscles. Since calcium is essential for smooth muscle contraction, reducing calcium-dependent signaling contributes to uterine relaxation. An important point is that magnesium sulfate is considered a relatively weak direct tocolytic compared with agents such as nifedipine or atosiban. Therefore, its current use is often driven more by neuroprotective and anticonvulsant benefits rather than pure suppression of contractions. One of the most important modern indications is fetal neuroprotection in very preterm labor. Administration of magnesium sulfate before anticipated early preterm delivery has been associated with reduction in cerebral palsy risk in premature infants. Another major indication is eclampsia. Magnesium sulfate is considered the drug of choice for prevention and treatment of eclamptic seizures. This makes it uniquely valuable because a single drug may simultaneously address maternal neurological protection and fetal benefit. Notice the low cost mentioned on the slide. This is clinically very important because magnesium sulfate remains highly accessible even in resource-limited healthcare systems worldwide. However, excessive magnesium levels can become dangerous. Adverse effects include muscle weakness, diminished reflexes, respiratory depression, hypotension, and cardiac conduction abnormalities. Therefore, careful monitoring is essential. Clinicians commonly monitor deep tendon reflexes, respiratory status, urine output, and serum magnesium levels during therapy. This slide highlights an important principle in obstetric pharmacology. Some drugs remain clinically valuable not because they are the strongest agents in one specific role, but because they provide multiple simultaneous maternal and fetal benefits. This slide compares approximate efficacy of various tocolytics in delaying delivery for at least 48 hours. Nifedipine and atosiban appear highly effective. This summary table integrates mechanism, advantages, and limitations of the major tocolytic classes. Nifedipine is effective, inexpensive, and orally active. Beta-2 agonists provide rapid uterine relaxation but significant maternal cardiovascular toxicity. Atosiban provides targeted oxytocin receptor blockade with relatively few cardiovascular adverse effects. COX inhibitors are highly effective in early preterm labor but limited by fetal ductus arteriosus toxicity. Magnesium sulfate is especially important for neuroprotection and eclampsia. Progesterone is more useful in prevention of recurrent preterm labor than in acute suppression of active contractions. The diagram integrates multiple uterotonic and utero-relaxant pathways. On the left side, oxytocin receptors, prostaglandin receptors, calcium channels, and alpha-1 receptors increase intracellular calcium and stimulate contraction. On the right side, nitric oxide, cGMP, beta-2 agonists, and potassium channel-related pathways promote relaxation. Notice how many drugs discussed throughout the lecture fit directly into this signaling map. Oxytocin activates oxytocin receptors. Prostaglandins act through prostaglandin receptors. Nifedipine blocks calcium entry. Beta-2 agonists increase CAMP. Indomethacin inhibits prostaglandin synthesis. Thanks for watching. Don't forget to like, subscribe, and share. Happy learning!